So let's directly start this video with a case. So there is an 8-month-old boy presented to the OPD with complaints of poor growth. He was born at term with birth weight of 2.4 kg, which means low birth weight, because low birth weight means less than 2.5. So this baby is 2.4. He was well in neonatal period until he developed feeding problems in the form of suck rest suck cycle. That means baby had to suck, then rest, and then again suck. That means that there was a component of heart failure, and this started from the 2nd month of his life. During the 3rd and 5th month, he was hospitalized with fever, cough, and fast breathing. What does this indicate? This indicates pneumonia. That to 3rd and 5th month means recurrent pneumonia, recurrent LRTIs. We must keep this in mind. On examination, the child looked thin and weighed 4.8 kg, which is less for 8 months. He was febrile and had a heart rate of 140 beats per minute, which is tachycardia. Respiratory rate of 50 per minute. If you recall the IMNCI guidelines, you will remember that less than 2 months, more than 60 breaths per minute is tachypnea. 2 to 12 months, more than 50 breaths per minute is tachypnea. So this baby is borderline at 50 breaths per minute and has subcostal retraction. So basically the baby does have pneumonia, fever and subcostal retractions and a high respiratory rate. Pulses were bounding in character and all peripheral pulses were easily felt. Blood pressure is 130 by 40. The SBP is 130, DBP is 40. That means there is a very wide pulse pressure. Pulse pressure is very high. SpO2 was 98% normal in all limbs. There was no cyanosis. This is a very important point. That means this is a acyanotic heart disease. We'll get to the diagnosis later. Precordial examination showed a hyperdynamic left ventricular apex outside the mid-clavicular line in the 6th intercostal space. Normally, it is the 5th intercostal space where the apex is felt. If it is shifted outside the mid-clavicular line and in the 6th intercostal space, that means there is left ventricular hypertrophy. Left ventricular. First heart sound was normal, but the P2 component of the second heart sound was loud. S3 gallop was heard at the apex, and very important, a continuous murmur was heard where with thrill. That means it's a very high grade murmur at the left infraclavicular region. Very important. Sliver was felt 2 centimeters below the right costal margin. That means there is some kind of hepatomegaly. All other systemic examinations were normal. Now let's look at the chest X-ray. Chest X-ray shows cardiomegaly because of the increased cardiothoracic ratio. How do we measure the cardiothoracic ratio? We suppose this is the widest diameter of the heart and the widest diameter of the thorax. So A by B should be less than 50%. If it's more than 50%, it's cardiomegaly. And we can see the apical contour is left ventricular type. If it was a right ventricular hypertrophy, the heart would be like this with the upturned apex, also known as boot-shaped heart, but it's not like that. It's like this. That means it's a left ventricular hypertrophy. Also, the pulmonary vascular markings, these are very prominent. We call this as plethora. What does that mean? That the pulmonary blood flow has increased. That's why it's so prominent. So what were the main points that we saw? The baby has a failure to thrive. Body weight is low. Baby is thin. Baby is not growing. Failure to thrive. Effort intolerance. Baby had a suck, rest, suck cycle. That means baby had to take rest in between feeding. That means there is a component of heart failure. And recurrent lower respiratory tract infections like pneumonias and also hepatomegaly. And other examination points that we saw even in the chest X-ray and the auscultatory findings that the apex was felt in the 6th intercostal space, that this is a left ventricular hypertrophy left ventricular. S3 gallop was heard, and there is a very loud P2. We'll come to each point more in detail. The most important point, which actually points towards this diagnosis, continuous machinery murmur all throughout systole and throughout diastole, a continuous machinery murmur. And the SBP was 150 and DBP was 40, a widened pulse pressure. And all these points help us make the diagnosis of PDA. Not public display of affection, but patent ductus arteriosus. And that is what today's video is about. Small disclaimer, I am not a subject matter expert. I am just a junior doctor who likes teaching. So without further ado, let's jump into this video. So in order to understand what is patent ductus arteriosus, we have to go to the story of what happens before birth, to fetal circulation. So in the fetus, there is ductus arteriosus, which connects pulmonary artery to aorta. So what is the location of this ductus arteriosus? This is right common carotid, this is left common carotid artery, and this is left subclavian artery. So right beside left subclavian is the ductus arteriosus. So what happens in a fetus? The lungs is almost non-existent, as in the fetus does not breathe, so there is no need of any blood entering the lungs. So this blood from pulmonary artery eventually is supposed to go to the lungs, so there is no need. That's why the blood gets redirected into the aorta. So if we come to this diagram, there is no need to send blood to the lungs, so all the blood gets redirected via the ductus arteriosus into the aorta, and aorta sends it to the rest of the body, because anyway we get oxygenated blood from the mother, so no need of lungs. So this is what's happening before birth. So before that, let's understand a bit of physics, right? In order to understand why the blood flows from pulmonary artery, which is the right side of the circulation, to the left side, it's a right to left shunt, right, in a fetus. Why does this happen? Why doesn't the blood flow in the opposite direction? So for that, let's understand a bit of physics. So PVR is pulmonary vascular resistance, the resistance provided by the lungs. So what is its formula? Pulmonary arterial pressure minus left atrial pressure. Why? Because in between the lungs, there is the lungs is in between the pulmonary artery and the left atria. So the resistance that the lungs is providing would be the difference between the PA and the LA by the perfusion of the lungs, the pulmonary blood flow. It's a bit complicated, but if you look at the formula for some time, you'll understand. So this is the formula. So in a fetus, in a fetal lung, there is no inspiration. So the resistance is very high. The lungs are basically collapsed, so the resistance is very high. So since PVR is very high, PAP, pulmonary arterial pressure, is very high. Simple maths, right? So since PAP is so high, it is much more than SAP. What is SAP? Systemic arterial pressure, which is basically the aorta. So we can say that the pulmonary artery pressure is much more than the aorta pressure. So blood always flows from high pressure zone to low pressure zone. So that's why in fetal circulation, it's a right to left shunt, and that is what is happening. High pressure pulmonary artery, blood is flowing to low pressure aorta. This is what is happening in a fetus. So what happens at birth? At birth, the baby will cry and start breathing. Blood will enter the lungs, and hence the pulmonary vascular resistance will decrease because air has entered the lungs. Also, we clamp the umbilical cord. Hence, the blood flow from the mother has stopped and the systemic vascular resistance has increased. So which was PAP was greater than SAP, has now become SAP greater than PAP. The systemic pressure, or the pressure in the aorta, is much more than that of the pulmonary artery. And hence the ductus arteriosus will constrict and become non-existent. So just to summarize, why before birth is the ductus open? Number one, so what I just explained, PAP is more than SAP. If there is blood flowing through a channel, the channel will be open. Also, the placenta provides prostaglandin E1. Prostaglandin E1 is very important to keep the ductus arteriosus open. That's why we'll later understand what's the role of indomethacin in PDA. We'll talk about that later. So what happens at birth? Baby starts breathing, pulmonary vascular resistance decreases, and PAP decreases. So the ratio, the PAP becomes less than SAP. Also, PGE1 at birth decreases, and hence at birth what happens? There's a constriction of ductus arteriosus in a normal baby. This is what happens normally. After birth, the ductus constricts and becomes ligamentum arteriosum, right? But this obviously does not happen in a baby with PDA. In a baby with PDA, there's a patent ductus arteriosus. So why do some babies have patent DAs, ductus arteriosus, whereas in mostly all babies it closes? First of all, some babies might have premature lungs. Oxygen has not entered the lungs. That's why the PVR hasn't decreased as much as it should, so the ductus remains patent. Number two, the prostaglandin circulation is high. That's why the ductus remains open. Number three, maybe the baby is very sensitive to PG, so even low level of prostaglandin in the blood will keep the duct open. Also, if the mother had rubella, which leads to something called CRS, congenital rubella syndrome, which causes, it's a triad, it causes deafness, cataract, and PDA most importantly. The thing that you must realize is that a patent ductus arteriosus is not the same as a normal fetal circulation. What many people think is that, oh, the ductus is patent, so it is the same thing that is there in a fetal circulation. But no, we must remember that in the fetus, blood flows from pulmonary artery to aorta, which is a right to left shunt. Whereas in a child with patent ductus arteriosus, the blood flows in the opposite direction from aorta to pulmonary artery. Because as we discussed, after birth, SAP is more than PAP. So aorta pressure is more than pulmonary artery. Blood flows from high pressure, which is in the aorta, to low pressure. What we must understand is that since blood flows from right heart, which has oxygenated blood, to left side of circulation, which is deoxygenated, so that's why there is no cyanosis. There is no cyanosis because oxygenated blood is going to deoxygenated, not the other way around. That's why this is a part of the acyanotic heart diseases. What else is there in acyanotic heart diseases? Congenital heart diseases where there is no cyanosis. There is ASD, atrial septal defect, VSD, and PDA, and coarctation of aorta. So PDA is part of acyanotic heart disease because it's a left to right shunt. Okay, so now with all this new knowledge, let's go back to our case. So the baby had suck rest suck cycle feeding problems, which is effort intolerance. And why was baby having effort intolerance? Because heart failure. Which type of heart failure? Right heart failure, right? And this starts from the second month of life, around 6 to 8 weeks, not from birth. And fever, cough, fast breathing, as we already discussed, recurrent pneumonia or recurrent LRTIs. And why was that happening? Because of increased pulmonary blood flow, plethora. More blood is going, more chances of infections, right? So on examination, pneumonia findings, okay. Why was the pulse pressure so high? DPP is low because blood in the systemic circulation is low, of course. And why is SBP high? Because since the blood in the systemic circulation is low, there is LVH. Heart is doing more work. more work is done by the heart, and that shows in the SBP. SBP is high, therefore pulse pressure is low. I know I don't need to explain why there is no cyanosis. It's an acyanotic disease. As I said, left to right shunt, hence no cyanosis. There is left ventricular hypertrophy, as we discussed, because the heart has to put in more effort to pump out blood, because all the blood gets redirected to the pulmonary artery. So the heart is thinking, the body is thinking that not enough blood is coming from the heart, so the heart pumps with more effort and hence becomes all muscular and hypertrophy. Right, so the P2 component of heart sound is loud. Let's come to that. So what happens in PDA is that there's a lot of blood in the pulmonary artery. So the pulmonary valve, there's so much of blood that the pulmonary valve P2 closes faster and closes with a very loud sound. That's why P2 was loud and narrow split S2. Right, and the most important point, a continuous murmur at the left infraclavicular region, the main part where the PDA is present. In that region, which is also called Gibson's area, is where we hear a loud continuous murmur which sounds like this. So very quickly we'll discuss the treatment of PDA. So the treatment is divided into medical treatment and surgical. So we'll first try the medical treatment, which is NSAIDs. Why? NSAIDs are basically inhibitors of prostaglandin production. And if you recall, PGE2 was what kept the duct patent. So anything that blocks PG production will cause closure of the duct. If that doesn't work, which it doesn't work in, it works in less than 60% cases. So then we'll do surgical management, which is either PDA ligation, which is basically, this is the pulmonary artery, this is the aorta, this is the connection. So we'll just ligate the two ends, or PDA closure device, or coil occlusion. We'll put in a coil inside the patent duct, and slowly over time it will constrict. So that's it for today's video on PDA, not public display of affection but patent ductus arteriosus. I hope you learned something. Keep thinking, keep learning.